Well, thank you, Chairman. I will give you a quick overview of the problem. You know that these new anticoagulants have been around now for a little bit over 10 years. They were first put on the market in orthopedic surgery for knee and hip replacement, and then they came into the general venous thromboembolic patients. There has always been a problem with cancer patients, and so far, and even still now, all the guidelines advise not to use the new drugs in most of the cancer patients. So what are we dealing with? First of all, as you know, VTE, venous thromboembolic disorders, is the second cause of mortality in oncology after the primary disease. So here you have large numbers of patients, and you have the incidence is somewhere between 5 and 20%, depending on the type of patients. The risk factors are very numerous. We are not going to discuss this in details. The only reason I'm showing you this is because most patients hospitalized have at least one or two of these. In Western Europe, median age at diagnosis of cancer is age 70. And if you go into a general hospital and you look at patients who are in a bed with age 70, whatever the cause is, a broken toe or whatever, they usually have more than one disease, usually more than two diseases. So they're all, in fact, have problems of thrombotic problems. With just 2 slides to get rid of the problem. You very often ask the question, what about hereditary thrombophilia? Well, the most frequent problem is the 5 mutation, the 5 LEIDEN, and overall in Western Europe and in most Western countries, it's around 5%, 3 to 7%, depending where. And here you have the risk ratios with estrogens, which you have no 5 LEIDEN, no estrogens, your risk is 0.8, and if you are homozygous, your risk is over 100 times more. And if you are heterozygous, which is the usual situation, and the patient is on estrogens, it's about 30 times more. The other question is, should you check for this? There have been several studies done in the early 2000s and in late 1990, and the general conclusion is if there is no family history, if there is no particular history with the patient, it doesn't pay to do the testing. So what are the risks? If you look at the different cancers, you have incidences. The relative risk is quite high in some cancers, as you know, in pancreatic cancer. And on this list of 13 different cancers, there are 5 of the GI area. So you have pancreas as the largest risk, then you have stomach, you have all the others, colon, and so on. That has to be taken into account. And if you look at in metastatic situation, patients with pancreatic cancer are at the top. And then you have other cancers. I like this slide. This shows you a little bit the risk over time. So at the moment the diagnosis of cancer is made, you have an odds ratio of about 5 times the normal. Then the patient is hospitalized, is being treated, and so on. The risk increases. The patient then gets chemo, immunotherapy, or whatever. And if he responds, the risk decreases. And if he's in complete remission, he's practically back to the normal population. But then, when metastatic disease comes up, the patient will, to the end of his life, be at a higher risk of venous thrombotic disorder. So, to make it easy, there is a score, the Corana score, which is now almost 20 years old, and was taken up again here in blood. It's very easy. You just look at the patient. The patient has stomach or pancreatic cancer. It's a 2, and if he has one of the others, usually platelets or hemoglobin stories and something like that, you add another point, and with 3, you are on the right side of the bar. That means the patient is at high risk of VTE. And that's what you see also in practice. This is a very large study done in Vienna by I, and you can see that this corroborates what the Corana score is. If you look at 6 months is where you have the red numbers. The score is quite high for patients the rate is quite high for patients who have a score of 3 or more. One question that comes up all the time, should ambulatory cancer patients be treated? There is no clear answer to that. There have been many studies done. Here is one British study in pancreatic cancer where you can see that the patients who had no treatment, they had a much higher incidence of VTE than those who were given dalteparin in this situation, low molecular weight heparin, and the same for pulmonary emboli. So treatment is efficacious. But then came this study, which is a very discussed situation. This study was published in GCO 4 years ago, but it was presented at ASCO 7 years before. You can see in these graphs that the incidence rate treated versus no treated is in favor of the treatment for VTE, and for major bleedings the difference is not very big. So it's more in favor of the observation, but the difference is not so high. But there were problems with this study. Here you have the curves, and one of these problems are listed up here. It was an open-label, unblinded, randomized study. There was no baseline screening at study entrance. There was no stratification for the different chemotherapy agents, which have a different incidence on the pathology of thrombosis, and I don't have the time to go into the details. The tissue factor story comes in here. And pancreatic cancer, you have 43% of the patients did not have any other risk factor than their pancreatic cancer, but those who had an additional risk factor would increase their risk to 6.3%, and if it was more than one risk factor, to more than 10. So this was a mixed group of patients, and it's very difficult to make a conclusion of that study, but it was very much discussed at that time because it's the only one of that size. So we're getting to the novel anticoagulants. So what are these drugs? These are drugs that are taken orally. You don't need to control lab tests, so they're just taken. And there has been a lot of experience in non-cancer patients. There have been many studies done, first, as I told you, in orthopedic surgery, then in general medicine. In the general medicine studies, there were cancer patients also included, but it was usually 3 to 5% and not enough to sort out a conclusion, and it would have been a retrospective, poorly done exercise, but it was being done at that time. So why do we need something different from what we have? If you look at the regular oral, which are antivitamin K, you can see here that the therapeutic window is very narrow. If you go beyond, then the risk of bleeding is very high, and if you go below, then the risk of thrombosis is high and your drugs don't work. And this is a nice study. This was in the same issue of the New England Journal of Medicine. Patients on warfarin at 4 weeks, only 45% of patients were in the target INR rate, and with the longer acting coumarinics, acinocumarol and fenprocomone, which are quite popular in Europe, about 60% were on target at 10 weeks. So it's a large number of patients who are not in the right target, so treated adequately. The standard is then, has become low molecular weight heparin. So what do you do with low molecular weight heparin? Obviously, it's daily injections. You have to monitor platelets because there is heparin-induced thrombocytopenia, which induces, despite the fact that it's thrombocytopenia, thrombosis. The cost is there. Some people live by themselves and are not able to do an injection or don't want to do it, so you have somebody else do it. And then you have other side effects, and the recurrent VTE is 5 to 7% at 3 to 6 months. The bleeding is not lowered but the major problem is compliance. So if you check people over a longer period of time, there have been several studies on this, the compliance is very variable. There are new anticoagulants. The first two ones are, the first one is certainly very interesting, is an antisense oligonucleotide against factor 11. There were several studies done and nothing happened since 2012. So I don't know why, but the product has not been investigated more. Semiloperin is an ultra-low molecular weight heparin, which there was one large Italian run study by Agnelli, who had treated patients, ambulatory cancer patients. The result was quite satisfactory, but development had been stopped by the company. So we have the oral ones, which are dabigatran, rivaroxaban, apixaban, and edoxaban. Depending what kind of area you're in, you're more familiar with one or the other. You should just stick to the one that you like, that you are familiar with, because there has been no difference shown, no significant difference shown between the different ones. We have then a certain number of studies comparing these new drugs to the standard, to the old standard, being low molecular weight heparin followed by antivitamin K. The treated cancer patients were small, as I mentioned, and then only over the past few years came specific cancer patient studies comparing the new drug to what has become the standard, though about 40% of patients are treated to an older standard, meaning low molecular weight heparin at the start and then continued with antivitamin K. So the specific studies that are recent were low molecular weight heparin as the control arm and then the new drug. So we have two major studies, which is rivaroxaban versus low molecular weight heparin, and edoxaban versus low molecular weight heparin. And you can see here the advantage of the drug is the VTE recurrence was improved, 4 versus 11%, but the major bleeds were slightly increased. And then the clinically adjudged or related non-major bleeds were also higher in both groups, and I will show you some data on that. So instead of going into all the details, I summed it up on the right-hand side of the slide, where you can see the VTE recurrence is in favor of the new drug. The major bleed is in favor of the low molecular weight heparin. The clinically relevant non-major bleed are not in favor of the new drug. And then the overall mortality, there's practically no change. So you're stuck with these two situations, an advantage on the thrombotic side and a disadvantage on the bleeding side. The recommendation, the general recommendation, we are not going to read them all. They are on the ASCO side, and they go back to 2015, as well as the ESMO recommendation, which will be updated soon. So hospitalized patients need to be treated if they have active disease, if they have cancer and active cancer or another active disease, admitted for pneumonia or whatever. Patients with CNS malignancy, that's a difficult situation because you might know that if you have been in labs, the tests that are being done, PT, APTT, are done with, or used to be done with phospholipids, which were extracts from rabbit brains. So you can have already changes in your coagulation after a commotion of the head. So there's always an increased, and you have seen that on the slide that I showed you with the incidence of different disorders. There's always an increased rate in brain tumors, and it can be difficult to treat because you can induce hemorrhagic situations, so you have to wage the pro and con in that situation. The relative contraindications, we're not going to, all this, bleeding ulcers or active ulcers, non-life-threatening, and so on and so on. So for the sake of time, I don't think we have to go through this. So what do we have as trials? We have in primary prophylaxis, these are patients, cancer patients, who have not had a thrombotic disorder, but that you think they are at risk. So you see the upper part of the slide was the standard treatment, comparing low molecular weight heparin with placebo, and obviously it's in favor of the low molecular weight heparin, the same with the second one. And then you have the semiloparin, which is the ultra-low, it's the number 3 on the slide, where development has been stopped. But then you have the two lower ones, which are apixaban and rivaroxaban versus placebo, and it's obvious that in that case you have an advantage, but you always have this little risk of bleeding. Now, in patients, that was primary prevention. Now, in patients who had thrombosis, what are you going to do? Here we have also the old studies, which are the upper 3, low molecular weight heparin versus antivitamin K. The studies are old, they are validated, and that's what has been done for many years, and still about, depending on the area, between 20 and 40% of patients are treated that way. But over the past few years, as I mentioned before, low molecular weight heparin has become the standard. And then you have the 3 new, these are the 3 only ones that have been done in a controlled fashion. There are about 5,000 patients who have been treated with these 3 patients, but many were observational, many were single institution ones. But it's interesting that the general conclusion, even with small numbers of patients, is always the same. So here you have the 3 lower ones, is edoxaban, rivaroxaban, and apixaban. These are all on the market. You know the names, I guess. So all you can say is that they are non-inferiority studies, they were non-inferiority studies, and you have always what I've been mentioning before, which is the kind of leitmotif of this presentation. You have an improvement of VTE, venous thromboembolic disorders, but it's at the cost of an increase of bleeding. So here, just rapidly, a few details. This is, you saw before the summary, but this is the randomized trial, the SELECT trial of Annie Young with rivaroxaban, and you can see on the right-hand side the advantage of dalteparin versus rivaroxaban. You have more venous thrombotic disorders with dalteparin. The same inverse for major bleeding, more with rivaroxaban, with the blue line. This is the other study, edoxaban, same thing. On the left-hand side, you have an aggregate of the data, but if you look at the right-hand side, it's again the same thing as before, improvement in VTE and increase of bleeding, major or non-major. And the third one, which was just published, you have here apixaban versus placebo, and here again you have the same thing. It's always the same story. So what are the conclusions? For the sake of time, I think we'll have to conclude a little bit rapidly. In general, venous thromboembolic disorders, it's a frequent situation, and you have to treat two targets, the cancer and the symptom. Biological alertness is necessary because many patients that you follow for a longer period of time, about 15% of the patients will have some kind of thromboembolic disorder. So it's all in the patient, hypercoagulability in cancer. The patients have to be followed. And you have to remember that VTE can be present before cancer, and the presentation of a VTE in a cancer patient is usually in the beginning of the evolution, of the clinical evolution when you see the patient. Low molecular weight is the treatment of choice, and it has to be continued in active disease. So if you have a patient who has active disease, you don't stop the treatment. And preventive treatment in ambulatory patients is not recommended routinely. So you have to judge the patient. Still, we are physicians, so you have to judge the patient, and you have the impression that the risk is high, you treat the patient. As far as the drugs are concerned, the new drugs are concerned, novel oral anticoagulants are not recommended in routine use. And if you look at the bleeding in the different studies, except for the edoxaban study, it's especially in upper GI and stomach cancer that you have an increased rate of bleeding. So the question comes up in GI cancer, what do I do in other situations? What do I do for colonic cancer if there is no big mass, bleeding mass or exophytic mass in the gut? What do I do with hepatic cancer and others, pancreatic cancer? There, it's all discussable. The International Society of Thrombosis and Hemostasis, which has the last guideline that just came up a couple of weeks ago, they strongly advise against treatment in upper GI and stomach cancer. So there are no standard recommendations for these drugs in the guidelines or in general cancer medicine, but we have about 30% of patients are being treated with these drugs. So I think that there's a good place for these drugs if you just judge the relative risks of the patient. What we don't have is a head-to-head comparison between the different drugs. So as of now, they are put in one bag, and what is good for one is said to be the same for all the others. You can have more reading if you're interested in Cochrane Library. This is about 70 pages that came out end of last year, and there is an update by in the Annals of Oncology. This is freely available. Thank you.